Okay. So this is a new lecture regarding the pathology of uh, what to call obstructive uropathy, and actually we are going to discuss about obstruction, and if there is obstruction, what will happen to the kidney. Understand? So, and one of the obstruction also we are going to discuss in detail is tumors. Okay. So this is about obstructive uropathy lecture, and inshallah after this lecture we hope that you girls can talk about, you can list the causes of obstructive uropathy and explain the pathogenesis of nephrolithiasis. Nephrolithiasis means renal stones, and if we call it as a urolithiasis, it means stones in the urinary tract. Stones in the urinary tract. If it is nephrolithiasis, stone in the kidney. Stone in the kidney. And inshallah, you can able to correlate and analyze the morphological, clinical, pathological features of pediatric and adult renal tumor. So, and you can also differentiate between the primary and metastatic renal tumor. Actually, I am not going to discuss this outcome. I am going to discuss instead of that how will you differentiate between the renal tumor and the renal pelvic tumor. Understand? What will be the clinical presentation if the tumor comes in the kidney and in the renal pelvis. Okay, so that is very important because metastatic tumor we discussed in uh, many organs. Like metastatic tumor means you have multiple deposits, so all over the organ that is the same. Understand? So inshallah we'll discuss about these things, and I hope you girls can discuss these things also. Okay, this is a normal urinary flow. Okay, so how the urine forms and it flows towards the bladder, and if there is obstruction, okay, so what happens is two things gets dilated. One is ureter, other one is kidney. Dilation of ureter is called hydroureter. It is called hydroureter, and dilation of kidney is called hydronephrosis. So if there is obstruction happening in the bladder, okay, so or below the level of vesicoureteric junction, below the level of vesicoureteric junction, whether the obstruction happening in the bladder due to tumor in the bladder, or there is a microbe called schistosomiasis. So that can infect the bladder, and it grows in the bladder, produce like a mass of worm. So worms that can block the bladder, or any papilloma benign tumor coming in the bladder that can block it, or any tumor coming in the urethra, surrounding the urethra, that can block the urine flow. And prostate in male, okay, so that goes for hyperplasia and it blocks it. Okay, so these are the things can block, but this block is happening below the vesic vesicoureteric junction. Understand? If there is any obstruction below the vesicoureteric junction, the hydroureter and hydronephrosis will be bilateral. It will be bilateral. If the obstruction is happening above the vesicoureteric junction, for example, obstruction is happening here, the hydroureter and hydronephrosis will be corresponding to that side. Corresponding to that side, it will be on this side, and hydronephrosis will be on this side. So hydronephrosis, unilateral hydroureter happens when there is obstruction above the vesicoureteric junction. Above the vesicoureteric junction. If the obstruction is happening at the vesicoureteric junction or below the vesicoureteric junction, it will be bilateral hydronephrosis, bilateral hydroureter. Okay. So what are the causes of obstruction? Okay, so if you see in any obstruction, you have to think of stones first. Okay, followed by any, for example, especially if the person is having long standing obstruction, for example, the person is having neurogenic bladder. Neurogenic bladder means the bladder is not able to do the micturition. due to lack of nerve innervation. So it could be of any reason. One of the reason is spinal cord injury. One of the reason is spinal cord injury. Okay, whatever it may be, the person cannot able to micturate, right? So what we do is we put a catheter. We put a catheter. So we'll take the urine out. We put a bag. So urine will be collected in the bag. So he has to drain the bag. Okay. So if any person is having long-standing catheter, okay, so he has a chance of getting damage to that mucosa. Okay, so you can go for fibrosis or you can go for stricture formation. Okay, so any interventional procedure happens. Interventional procedures, nowadays we do lot of interventional procedures. That's why I'm changing the causes which is given in the book, okay, on practical grounds. So stones are most commonest one. Then you have to think of any interventional procedures has been done in the lower urinary tract. Any interventional procedure like catheter or putting some catheter and taking the fluid out for the diagnostic purpose. So any interventional procedure has been done, you have to rule out that. Then you have to think of other general causes, like if the person is pregnant. Okay, so like those causes you have to think. Then last come to the tumor. Okay, so tumor should be the last most thing you should think when there is obstruction. Understand? Don't immediately jump into the first cause of urinary tract obstruction. So what happens is whenever there is obstruction, if the urine stays there, normally the bladder urine is sterile. Bladder urine is sterile. So because sterility is due to the pH and as well as due to the transitional epithelium of the bladder. If the if there is obstruction, for example, the prostate is enlarged in a male, so it is causing urethral obstruction. Okay, so the urine stays here more. Understand? If the urine stays here more, infection is very common. Infection is very common. Inshallah, we'll talk about the bladder infection and bladder tumors in the next lecture. So this is infection is common. So this infection, once the urine stays there, so it goes for the backward flow. It goes for the backward flow because it goes for the dilation, and the kidney goes for the dilation. The infection travels there. Okay, and there is high chance for having acute pyelonephritis. High chance for having acute pyelonephritis along with hydronephrosis. Along with hydronephrosis. Understand? Okay, so this is are the most commonest cause. So it can come in the renal pelvis or it can come in the ureter. Ureter means you have to think of any intrinsic cause or extrinsic cause. Extrinsic cause, example, pregnancy or tumor in the surrounding areas, that is retroperitoneal areas. Or for example, if there is massive hematuria happening, that can form a clot here. That can form a clot here, that can also block. Or if there is a papillary tumor here, the papillary is very fragile. It breaks and it can come down and it can block. Understand? So these are the intrinsic causes of ureteric obstruction. And coming to the bladder, remember the most commonest one is again calculi in the bladder, then tumors. Tumors also we have to think of most commonest is benign tumors, okay, papillomas. Then neurogenic bladder, that is functional obstruction. That is functional obstruction. Okay. Now coming to the urethra, if it is a male, always think of prostate. Always think of prostate. This is the most commonest one causing obstruction, especially in the elderly male. Especially in the elderly male. So, so these are the causes of obstruction. Okay, now coming to the renal stones. Okay, if it comes in any part of the tract, it is called urolithiasis. So normally it can come at any level in the urinary collecting system, and it is more common in the men. And now this is very important. 80% of the renal stones are calcium stones. 80% of renal stones are calcium stones, whether it is calcium oxalate or it could be of calcium oxalate plus calcium phosphate. Understand? Mixed stone or pure calcium oxalate stone. Okay, so 80% of the stones are calcium. So rest of the 10%, okay, stones is called triple stone: magnesium, ammonium, phosphate. Okay, so these stones usually seen in infections, usually seen in infections, and because the infections alters the pH, okay, it increases the pH, so these stones are formed. Magnesium ammonium phosphate stones are formed, otherwise called as struvite stones, otherwise called as struvite stones. And another type of stones are due to metabolic disorders, due to metabolic disorders. For example, if the person is producing lot of uric acid, person is producing, there is a condition called gout. Okay, inshallah we'll discuss more in the MSK module, that is called gout. Okay, so here there is some enzyme deficiency which leads to increased breakdown of certain metabolic products that leads to uric acid. Okay, that uric acid is deposits in the soft tissues, it deposits in the soft tissues near to the bone as well as in the kidney. So if it deposits in the kidney, it forms uric acid stones. Uric acid stones. So calcium can also join with uric acid. Calcium can also joins with uric acid. Cystine stones are due to certain amino acid transport problem. It's a congenital. So some persons have transport issues in the amino acid. So that amino acid gets collected. So it is called cystine stones. This is called cystine stones. See, 80% of the stones are due to calcium, which means the person is having more calcium, right? The person is having more calcium. The calcium can come from increased absorption of calcium from the GAT, increased absorption of calcium from the GAT. And if you see calcium, 99% of the calcium are stored in the bone. 99% of the calcium are stored in the bone. Or if there is increased destruction of bone. Okay, these are the main two pathway of getting calcium in the blood. There may be increased absorption and there may be increased destruction of the bone. So what are the causes for metastatic calcification which you studied in the POD? The same causes comes here. Same causes comes here because increased vitamin D, which removes the bone from the, which removes calcium from the bone, and hyperparathyroidism, which removes calcium from the bone. Understand? So these are the reasons, and another 2 3 reasons inshallah we'll discuss detail in MSK module, okay, and endocrine module. Okay, so these are the two reasons, yani, like there could be increased absorption or increased destruction. Okay, so whatever it may be, the calcium is coming more in the circulation, it is going to the kidney and it is depositing there, it is depositing there. Why calcium is depositing there in the kidney? See, if there is increased calcium, okay, hypercalcemia, and it deposits in a normal tissue, it is called metastatic calcification, right? It will not deposit in all the tissue. It selectively deposit in 4 tissues: kidney, lung, gastric mucosa, and blood vessels. Why? Hmm? No. See, why it's going to the kidney to get filtered, okay, because for the filtration process. But why it is depositing in why it is depositing in lung, why it is depositing in gastric mucosa, why it is depositing in blood vessels? He said maybe due to reflexes. No. Huh? Or the pressure. Calcium deposits in alkaline medium, okay, which means that tissues are more alkaline. Okay, gastric uh, yani, gastric mucosa is alkaline, but it secretes acid. Understand? It secretes acid. Gastric mucosa is alkaline, that's why the calcium deposits there. And blood vessel wall is alkaline, so that's why the calcium deposits there. And lung interstitium is alkaline, so that's why the calcium deposits there. Likewise, renal interstitium is more alkaline, that's why they deposits there. Understand? So this is very very important. Okay, I think I must have discussed in the theory. Okay, anyway, but many students say that I didn't discuss that. Anyway, okay. So calcium usually deposits in alkaline medium. So these are the 4 tissues you see metastatic calcification. One is blood vessel, easy to remember. All these are except gastric, all the other organs have more vascularity. Kidney, and the lung and blood vessel. So if you remember the vascularity, you can name this. Okay, kidney, lung, blood vessel, and apart from that, gastric mucosa. Okay, so these are the organs where you see calcification. So which means that if there is hypercalcemia, there will be deposition of calcium, and that also happens in the kidney. That is one of the reason for uh, calcium stones in the kidney. Okay, so what happens is there is increased urine concentration of stones constituents, which means here the calcium. Okay, so then they cannot able to solubility nature is exceeded, so that is called saturation. That's the saturation limit, right? So automatically it becomes super saturated, so the stone cannot be dissolved, the calcium cannot be dissolved. And remember, this all the mechanism are like kind of hypothesis, understand, it's not like 100% accepted, but 50% of the hypercalciuria happens if there is increased absorption. Okay, increased absorption. And rest of the hypercalcemia happens due to the hyperparathyroidism, vitamin D intoxication, or chronic inflammatory conditions, okay, like sarcoidosis. And 20% happens because of uric acid. Okay, so because I told in the beginning, uric acid also, calcium also joins with uric acid and they form the uh, urate salt. And it can also joins with oxalates, oxalic acid, it can also joins with citric acid. Okay, these are the reasons for calcium stone formation. Most importantly, the high urine pH will favor the calcium deposition. High urine pH, that is alkaline pH, will favor the calcium deposition. So other stone formation, the reasons are little bit better understood. That is magnesium ammonium phosphate, which is commonly seen in these infections, Proteus vulgaris and Staphylococcus infections, that increases the pH. The bacterial infection will increase the pH, that leads to the stone formation. And uric acid stones are formed in metabolic disorders like gout, or if there is rapid cell turnover. Rapid cell turnover means if the cell is dividing fast, then they also die fast, right? When more number of cells are produced, more number of cells will die. Okay, that's what happens in leukemia. Leukemia is a blood cancer. Okay, more number of cells are produced, more number of cells will die. So that when the cell dies, we form more uric acid. Okay, that inshallah we'll discuss more in MSK, how the uric acids are formed. So now we understand, if there is more DNA destruction, uric acid is the byproduct. Uric acid is the byproduct. So uric acid level will be increased. So that uric acid will be deposited in the kidney. That leads to urate salt formation. Okay, and this also I can tell one more example. And if the person is having cancer, we give treatment, right? What is the treatment? You want to kill the cancer cells, right? When you give the cancer, you want to kill the cancer cells, more uric acid is formed. Understand? So in those conditions, whenever more cells are dying in the body, you get more uric acid because of DNA destruction, and DNA will lead to uric acid. Destruction of DNA will lead to uric acid formation. Okay. Now cystine stones are formed basically due to some transport issues of amino acids, and it is also genetically determined defect. Okay, and most of the stone, all the stones, I think, are forming because of low pH, high pH concentration. Actually, here the low pH concentration favors the cystic stone formation. Understand? So now coming to the renal stones, and again there are certain inhibitors of stone formation. Okay, for example, if you see the certain persons, and they are hypercalcemic, but they will not form renal stones. There are some people, they are hypercalcemic, okay, they form renal stones. Then they analyze why there is this difference is happening, and they found that there are certain inhibitors of stone formation. Okay, at your level, please understand at least one protein. There is a protein in the uh, tubular epithelium. This protein actually inhibits the stone formation. That is called Tom Marshall protein. This protein also we saw in the acute tubular necrosis. Okay, so these proteins can come in the urine. That is seen as a proteinase cast in acute tubular necrosis. Okay, so any deficiency of these substances can lead to stone formation. So the stone may be very small size, like 2 to 3 millimeter, or it can be very large like this. Okay, when it is large like this, we call it is a stag horn. Okay, it is like an animal horn, no? So it is like a stag horn uh, calculi. When you see a large stone, we suspect magnesium ammonium phosphate. When we see a large stone, we suspect magnesium ammonium phosphate. And remember, most of the times the stones are formed in the renal pelvis or in the bladder. Okay, if it is a urolithiasis. Okay, but its stone can form at any place in the kidney, but most commonly seen in the renal pelvis and in the bladder. Okay, so when you see a large stone, suspect magnesium ammonium phosphate. When you suspect magnesium ammonium phosphate, you should suspect urinary tract infection. That too specifically Proteus vulgaris and the Staphylococcus. Okay, now coming to the uh, renal stones going and forming ureteric stones. Okay, so stones can be formed anywhere else, and usually it passes through if it is small. Understand? When it is small, if they see the narrower lumen, it gets obstructed. Okay, when it gets obstructed, it creates severe pain, that is called urethral colic. That is called urethral colic, and it is like a paroxysmal pain. Paroxysmal pain means it appears all of a sudden. Understand? So, and it starts from flank and radiating towards the groin. Okay, so that is the most characteristic pain, and that is colicky pain, and it is a paroxysmal pain. And when you have such pain, and easily will suspect urethral stones. Understand? So if you then they do certain investigation called ultrasonogram and intravenous pyelogram, and that will tell you where the location of the stone. That will tell you exact location of the stone. Then they do a. Have you heard of ESWL? Yeah, it is called electric shock wave lithotripsy. Okay, so they do ESWL. Yeah. So they send a shock wave and they destruct the stones, and the stones will become smaller in size, and it comes out in the urine. Understand? So this is called lithotripsy. It is called lithotripsy. Remember, whenever there is stone, okay, it keeps on doing aberrations. Okay, so which keeps on the patient may have fresh blood in the urine. Understand? There is a difference in morphology of the fresh blood and the blood coming from the glomeruli. Understand? So the two morphology is different. So when you see a fresh blood coming in the urine, we suspect urinary obstruction, urinary tract obstruction, and this person will have more prone for UTI, more prone for UTI. Actually, this lecture and the previous lecture is related to PBL. Okay, so inshallah, in the tutorial we discuss PBL as a entirely. Now coming to the hydronephrosis. So you all know, if there is obstruction, it causes dilation of the renal pelvis and calyces. It is called hydronephrosis. What happens is, now okay, now the first the dilation happens at the pelvis, right? Then it goes to the calyces. Then it goes to the calyces. So automatically the cortex is compressed. Cortex is compressed. So the all the structure in the cortex will go for, raise my voice. Okay. So when there is obstruction, okay, when there is obstruction, I think this is my maximum. Okay. So when there is obstruction, and if the first dilation happens in the pelvis, then the dilation happens to the calyces. So now dilation happening to the calyces, which will going to compress the cortex. So automatically the cortex will go for atrophy. Understand? So this is the most dangerous event happens in hydronephrosis. So slowly the GFR falls down. Slowly the GFR falls down. So that's why we should not allow them to go for hydronephrosis. Otherwise, it's only a morphology. You should not think it is a morphological event, because it is going to compress the cortex. So we should not allow them to go for hydronephrosis. So like they will do the atrophy of the renal parenchyma. Parenchyma means we mean the main component, that is the cortex. So the most commonest cause is congenital. There could be some atresia of the urethra, or sometimes urethral absence could be there, or urethral wall will be permanently closed. So these are the things we have to do surgical procedure to open up the urethra. We have to do surgical procedures to open up the urethra, or the person's most of the commonest causes acquired, okay, calculi or papillary tumors, so or inflammation like prostatitis, neurogenic cause. Like all the obstruction cause can cause hydronephrosis. All the causes of obstruction can cause hydronephrosis. So this is one I explained in starting of the lecture. When bilateral hydronephrosis happens, when unilateral hydronephrosis happens. So remember vesicoureteric junction. Okay, if the vesicoureteric junction obstruction happening at the level of vesicoureteric junction or below the level of vesicoureteric junction, okay, it will be bilateral hydronephrosis. If it is happening above, it will be unilateral hydronephrosis. Okay, now this is very important of all the slides. Okay, see, there is a difference between complete obstruction and partial obstruction. If there is complete obstruction, so now let us take a kidney. Okay, now there is obstruction here. Now consider this is a tubule. Okay, so what happens? The urine is not coming around, right? So it stays here. It stays here. Automatically, this will dilate it, right? This will be dilated. The tubules also will be dilated, right? Tubules will be dilated. When the tubules dilated, slowly the urine leaks into the interstitium. Leaks into the interstitium. The problem is now still the glomeruli is not affected because glomeruli will keep on doing their process. So the urine is filtrate is coming, understand? But there is obstruction, understand? So now from the above the fluid is coming. Now the fluid is not going down, and now the dilation of the tubule becomes worse, right? It's keep on dilate. Sometimes they rupture, okay, and all the fluid leaks into the interstitium. That will create massive inflammation. So this kind of situation happens in complete obstruction. That leads to oliguria and azotemia. Okay, now let us talk about incomplete obstruction. In incomplete obstruction, now there is mild dilation of the tubule. Okay, it will not be dilated like complete obstruction. Complete obstruction, they start leaking the fluid into the interstitium, understand? Here they will not leak the fluid into the interstitium. There is no interstitial inflammation, but there is dilation. So the urine is staying there for a longer time in the tubules. That will make them to lose the brush border. The tubular processing is affected. Tubular processing affected. Have you ever heard of urine electrolytes? See, serum we check the electrolytes. Likewise, in urine also we check the electrolytes. Understand? So you all know how the sodium gets absorbed, how the all the bicarbonates, everything gets absorbed, everything you know. Okay. So then inshallah then I will include that in the case history. So serum electrolytes values. Okay. So it is very important because inshallah while I am discussing the tutorial I will discuss more about cases. That time I will tell you why it is important. So serum urine electrolytes only give us whether the tubular processing is happening or not. Okay, if you can't able to analyze the serum electrolytes, you cannot give the diuretics, you cannot understand what is happening at the tubular level. Okay, so one of the two electrolytes which is critical in analyzing the urine electrolytes is sodium and the bicarbonates, understand? So now what happens here is the tubular epithelial cells lose their brush border. Automatically they cannot do their normal processing, so they cannot able to concentrate the urine. Now the urine flows more, okay, into the pelvis, so it goes for polyuria. The exact opposite thing happens in partial obstruction. In complete obstruction there is oliguria and azotemia, whereas in partial obstruction there is polyuria, understand? Okay, now which obstruction the patient is high chance to go for infection? Hmm? Actually both the obstruction, understand? So any obstruction there is high chance for infection, understand? So don't get confused like this, huh? So any obstruction there is high chance for infection, whether the urine stays for little amount or larger amount, So only thing is staying of urine or staying of filtrate will leads to infection. That is the concept. Okay, now coming to the morphology. So the kidney may be massively enlarged. So when they enlarge, you can see it is cortex is, see here, the here it is not causing the compression of the cortex. Here it is, cortex is completely compressed. Okay, so this is the damage they create, and there will be tubular dilation that leads to tubular atrophy and fibrosis. You can see that dilated tubules inside, they are having fluid, right? It's all dilated and they are rupturing and the fluid is going, so you are seeing the inflammation. You are seeing the inflammation. Understand? So this is what happens in the hydronephrosis. So bilateral complete obstruction produces anuria. Incomplete obstruction will cause polyuria. So most commonly it causes polyuria, and this leads to, due to the defect in the tubular concentration mechanisms. And unilateral hydronephrosis may remain completely silent because other kidney is functioning normal. Unless other kidney is affected, we cannot able to identify the disease. So most of the times we identify the disease as accidental findings. Okay, so this is about hydronephrosis. Now coming to the renal tumors. And the renal tumors, there are benign and malignant tumors. Okay, but malignant tumors becoming more important in kidney because benign tumors are very rare. Okay, we don't see much, and if it comes in the adult, we call renal cell carcinoma. In so adult tumor, other name is hypernephroma, and pediatric tumor are called as Wilms tumor or nephroblastoma. It is called as Wilms tumor or nephroblastoma. And coming to the renal pelvis is lined by the transitional epithelium. So the cancer coming from that, it is called transitional cell carcinoma. It is called transitional cell carcinoma. So coming to the renal cell carcinoma, it arises from the renal tubular epithelium, and it is the most commonest malignant tumors, and it is seen in the elderly age, 6th to 7th decades, and it is common. It is more common in the male, and remember it produces hematuria along with polycythemia. Polycythemia means increased in RBC because these tumor cells secrete erythropoietin. These tumor cells secrete erythropoietin, and usually it will be unilateral, and it will be a yellow color tumor because it contains lot of cholesterol. It contains lot of cholesterol, so it is yellow color, and it usually seen in the poles of the kidney. Understand, whether in the superior or inferior pole. Okay, now there are four types. Clear cell type is the most commonest one. Clear cell type is the most commonest one. It could be of papillary type, or it could, if cytoplasm has some granular appearance, it is called granular cell type. And chromophobe is, they have a clear cytoplasm, very distinct central nucleus. Okay, it is like a bullseye. Understand? So yes, I'll show you. Clear cell type means they have very clear large cell with clear nucleus, and they have a small dotted clear cytoplasm, small dotted nucleus. This is the most commonest one. Chromophobe means the cell size is small and they have an appearance like this. The cells will look like this. You know, any bullseye, any fried egg. Okay, so we call bullseye. I don't know what you guys call. Okay, so it is a, just you make a egg and put it in the pan, it gets fried, right? So you can see the egg yellow, right? Like that kind of appearance. It is called chromophobe cell type. Okay, so there are four cell types. Okay, I'm inshallah we'll discuss that in the lab. So one is clear cell type, is the most commonest one you see in the renal cell carcinoma. Okay, Wilms tumor, it is seen in the children of 2 to 5 years of age, and it is a large tumor, and it will be well circumscribed. It will compress the normal kidney. It completely replace the kidney with tumor, and you'll be seeing white to grey color of the tumor, and some areas will have hemorrhage and necrosis. And it has four components, basically very important. Blastemal component means undifferentiated cells. Okay, highly proliferating cells, undifferentiated cells. You will not see cytoplasm, only nucleus will be seen. Cytoplasm is very thin. That cells are called undifferentiated cells. and if they differentiate, they will differentiate into glomeruli and tubules. If they differentiate, they will differentiate into glomeruli and tubules. So you see one side of the tumor undifferentiated cell, and another side you will be seeing glomeruli and tubules. Another side you will be seeing glomeruli and tubules, and you will be seeing stromal cells, that fibroblast, all the stromal cells you can see, and most importantly anaplastic cell. Normally it is 5%. Okay, so actually it is seen in 5% of cases. Even in the tumor it is seen as a 5%. Okay, if it is more, if the anaplastic cells are more and the blastemal element is more, the prognosis is bad. The prognosis is bad. So whenever anaplasia happens, it is more, then the prognosis is bad. If the anaplastic cells are very less, the prognosis is good. So, and this tumor also produce hematuria. Okay, so this is about nephroblastoma, and inshallah this we will discuss in the lab, and I want to discuss about the most important concept. Please don't go, still I have not finished. See, there are two, just I am giving example of two tumors. Okay, one is in the pole. What will happen to the GFR and GFR and the serum creatinine level in this case? What will happen to the GFR and serum creatinine in this case? And there is a pelvic tumor. This is a renal pelvis. There is a tumor here. What will happen to the GFR and serum creatinine in this case? Anyone. For this case A, what will happen? GFR increases, decreases, then increases. For this case, GFR is normal and serum creatinine normal or increased? Oh, increased. Okay. How many classes is over for so far in GU1? How many weeks passed? Only 1 week is left. You all have to redo the GU1. Actually, first of all, I want to ask you what logic you had when you say normal GFR and increased serum creatinine. And okay, let us explain. Please listen. See, these tumors are in the pole, right? You see, large area of the kidney is normal, right? Right? So, and this will maintain the GFR. Okay, serum creatinine will be maintained. Here, the tumor is in the pelvis. It is producing complete obstruction. So GFR, because it will slowly backward pressure happens, GFR will be affected. GFR will be reduced. There will be increase of serum creatinine. So this case will have oliguria or anuria. If it is bilateral, it will be anuria. Now I gave a history, like you have to think in a bilateral. So it is a case of oliguria or anuria with azotemia. This case will be normal GFR and normal creatinine. Understand? Okay, this also I can digest. I cannot digest this concept. Okay, so and please seriously study the things and apply the knowledge. Understand? Otherwise you will not you will I don't want to say such words. You will land nowhere. Okay, so please put your concept correct. Inshallah we will discuss more. Come for the lab. You want to combine? No, actually you can't combine. This much of students can't sit there.